that, and you can really see all the huge advancement in science and technology in this part of healthcare. So let's lean more into the process of becoming a parent. Typically, you would hear before the introduction of scientific health, our forefathers really relied on maybe herbs and concoction as their sole means of having kids. What would you say to couples or let's say women right now who rely solely on that?
All right. Personally, I don't have issues with herbal medications. Where my issues are the fact that most of them are untested and unregulated,
Okay.
and then have no specific dosages.
Okay.
Right. But then, if whatever you are using is tested, regulated, and have dosages,
Okay.
yes, you can go ahead and use
Okay.
that.
Okay.
Yes. However, the ones that are not tested tend to have so many complications: renal issues, liver issues, blood issues, and then eventually it even delays your whole process of trying to get pregnant. Yes, I've had a personal experience where lady has fibroids and was told that she should insert some concoction into her vagina that will allow the fibroid to come out.
To disappear.
Yes.
Wow.
And interestingly, for her, she said something came out from her vagina, which she thought was fibroid.
Wow.
And then later she realized that she was not menstruating.
Oh.
And then that was the main reason why she came. And then what happened was that the herbs that she used had burned her whole entire vagina. And the vagina has closed up.
Oh my
For
God.
vaginal stenosis. So for a patient now who wants to actually get pregnant, the whole entire vagina is closed.
Wow.
All right. So
Wow.
if whatever you are using is tested and regulated, then you are allowed to use it.
Okay.
If it's not, I don't recommend you should.
I mean, it sounds like this horrific risks to using these unregulated types of concoctions. Would you recommend government at least stepping in to regulate some of these concoctions?
Yes, I think there should be legislation to regulate such things. Unfortunately, in our country, it looks like, I think government is doing enough, right? But they should put in more efforts to make sure that they regularize most of these medications, make sure that they are up to par, and then do not cause so many complications, right? And then I also do not want to sound like I have something against herbalists or these kind of things. But I think they can also try and make our work more easier by being advocates and educationists for us. Where you try and then you realize that it's not working, then refer the patient or the client to a higher center.
At least it's
so
an
that,
option.
Yes, you can also try those options as well.
Amazing. I definitely like that. One thing that I want us to go back to, one thing you mentioned when we're assessing the health of a woman in trying to get pregnant is diabetes during, that preconception phase. One of the concerns that I've heard of in pregnancies is preeclampsia. Can we talk about that a little bit? Because I feel like it will be helpful for women to at least have some knowledge or awareness around some of these types of complications. And this seems like one of the most concerning ones you typically hear of. So school us a little bit on preeclampsia in pregnancy.
So I want to start this way. In Ghana and in Africa as a whole, most of the mortalities and then the morbidities we have with women that actually get pregnant has to do with bleeding. The next thing that causes mortality, that is death, is what we call hypertensive diseases in pregnancy.
Wow. So the number one, I want to reiterate this. The number one cause is bleeding, like excessive bleeding.
Yes.
And then number two is
It's
this
hypertensive disease in pregnancy,
Got
of
it.
which preeclampsia is one of it.
Wow.
Yes.
Okay.
Now, preeclampsia happens when you have abnormalities of your placenta, right? And then during your placenta, during your pregnancy, your placenta forms. Okay. I don't want to bore you with all the details. However, there is some defect in the placenta formation, right, that leads to high blood pressure and then its other sequelae and complications. Okay. And basically, it is a diagnosis that we make after 20 weeks of pregnancy. And it's defined as when your blood pressure is more than 140 for systolic and then a 90 for diastolic with end organ damage. All right. And the end organ damage can be anything because there's blood everywhere in your system. It can start all the way from your head. So you can have stroke as a complication. You can have blurred vision. You can have epigastric pain. You have pain somewhere here. Your liver can rupture as time goes on. Your kidneys can be affected, right? And then in the long term, it affects the baby itself, such that the babies are born either small for their gestation, they tend to even die before their time. So it is quite a huge problem that we have. And unfortunately, there's not much education on it. So I'm glad that you brought it up. It is something that can be actually tamed. It's something that we can deal with. And it all has to do with taking a history. Because once a patient has had preeclampsia in their previous pregnancy, the chances of them having it again is quite high. Okay. So you need to put measures in place to make sure that they don't have it. And even if they do have it, you need to pick it up early and then manage it accordingly throughout the whole pregnancy to avoid the complications that they are bound to have during the pregnancy.
Well, thank you so much for that, because I think most women would like to at least know some of these issues or concerns or complications that could erupt during that pregnancy journey.
Talking about education, right, like you rightly mentioned, with the preeclampsia and other possible complications in pregnancy, we also have like I'm all about women and supporting women and ensuring safe pregnancy, and safe motherhood. So we also have this pregnancy school program, which is like free, open to every woman. You just joined, still a WhatsApp group. We still have, like I mentioned, our team, the midwives, everybody is on that platform.
If women want to join, how do they find this resource group to join?
Okay, so we could share the number with them. So you could send a hi to myself on 055 956 3252, and then we add you to the group. Or you could go to the hospital's website and then you call the number there and then we add you. It's a platform for every woman or every pregnant woman. And what we do is we offer education on possible complications of pregnancy, what a normal pregnancy is like. And then you have access to our experts, just like Dr. Intelma is on the page. She will gladly explain everything to you.
Wow.
So
I love that. I really love the work that you're all doing, not just when patients are in here, but even those who are not in here in your facility, just providing that education and awareness to the community. And I think the health ministry, if you're watching this, you need to. This is awesome. As we're on the topic of complications in pregnancy, I want to shift our attention a little bit to STDs, sexually transmitted diseases. Do they interfere with pregnancies? And if so, how?
Okay, so as part of the screening, like you mentioned, the test we do an STI panel. That's a sexually transmitted infection panel for all our clients, or I mean for every patient before you start a fertility journey. Diseases such as chlamydia and gonorrhea do impact your fertility a lot. Most people are walking around without any signs or symptoms. They don't even know that they have these infections going on. However, it's not really much of a problem because we're able to control them with antibiotics. So usually we diagnose you and then we put you on antibiotics for like a week or two, and then we monitor, we recheck, repeat the test to make sure the infection is cleared before we start you on any fertility treatment, or we even advise you to get pregnant.
Okay, awesome.
To add on that, what actually happens if you don't treat sexually transmitted diseases? For men, for instance, they are not able to even produce any sperm at all.
Wow.
Yes, they can have stenosis of their whole urethra, where the semen is supposed to come from. Yes, so they are not able to produce at all. For the women, their tubes get blocked most of the time, and you need your tubes to be open for your ovaries to be able to pass through that, all right? And then even if they are blocked for one way or the other, they tend to affect the success rate of our IVF cycles. So then it means that if you have issues with your tubes, then we need to take those tubes out. Yes, otherwise, most of the time, the IVFs we are going to do will not fail. So STIs have a huge impact on fertility.
Let's talk about delivery. One of the assumptions that you hear is usually women don't have a choice or they don't have the access to make a decision who to save in a case of huge complications, right? So, how do you determine who is priority? Is it the child or the mom, or is this left to the dad to decide who we need to save in any type of unforeseen complication, like a fatal complication?
Okay. So basically, as OBs, obstetrician gynecologists, our contract is actually with the woman. Yes. Unless the patient or the woman has some other person who will make those decisions for her. But then that is in the cases where she's unconscious or she's in a state where she can't make the decisions herself. But most of the time, the contract is with the woman. We will always choose the woman over the baby any day, any time, because we want you to be healthy, we want you to be alive, to be able to make another baby. All right. Yes. So in situations where we have to choose one over the other, we always choose the mother over the baby.
Awesome. Sounds good. Perfect. I like that you mentioned that because this is some of the questions that I would hear having conversations with women in general. And it's like, well, I'm not so sure if anything happens, who's going to be saved? Is it a baby or myself? Or do you leave it to my husband to make that decision when he really didn't inform this person? So I'm really glad that you're able to give us a response for that. And to top this, this is a fertility center. As you mentioned, it's a home for those who are looking to have children. In any of the treatments that you've had so far, have you gotten to a point where you have suggested to a couple or maybe a mom to look into surrogacy as an option? And what will the reason be to suggest surrogacy?
Okay, so just as Dr. Intiawan mentioned, it's a whole journey. We don't just start and we jump to surrogacy. Like he said, we have the stimulation for natural cycle. He mentioned the IUI, he mentioned the IVF, he mentioned the ICSI, right? These are all treatment options. In some couples, they have the liberty of going through the various stages before we get to surrogacy. In others, however, we may just have to jump up to surrogacy. For example, in a case where we have a man with an STI which wasn't treated, and he has urethral stenosis in which the sperms can come out, the only option might be to probably do a semen biopsy. That's as we poke in and then we take out the semen. That's even if he's producing enough for us. In women who have blocked tubes, which means that the eggs, I mean, we can release an egg all right, but then the egg can't move through the tube to meet the sperm to fertilize. That means you have to do an IVF. In patients with like maybe endometriosis or very huge fibroids, or people who have had to do myomectomy, that's taking out the uterus, or people with unexplained infertility, like he mentioned earlier, our resort might be, or in patients who have also had like series of failed IVFs, unexplained ones, of course, we do sometimes suggest surrogacy to them. And it will interest you to know that we do have a lot of people who are leaning towards that. I mean, like I said, science has really developed, and I think the society is more informed that opting for a surrogacy doesn't make you less of a parent, right? So we have different options in the surrogacy. I mean, the surrogacy is like the broad term, but then ideally we have like the carrier, and then we have the donor sperm and then the donor egg. These are various options. So we could have a case where in patient A, maybe the man is not able to produce enough sperms. So we take the woman's egg, and then, or let's say you produce sperm but it's not enough, we go to the lab, we try to prepare the sperm, but you're not getting very good sperms. Or you've gotten good, but we would want a backup. So your woman, your wife, or the surrogate mother wouldn't have to go through the process twice. So then you use your sperm plus a donor backup. So let's say your husband's sperm and then a donor sperm as a backup. All right. So then we can either use your wife's egg, we fertilize the two in the lab, and then we just put it inside the uterus. That's where I already explained, of the carrier. That's a surrogate mother. That's one option. Another option could be that maybe the woman is old, she probably didn't know about egg freezing as an early stage, so she didn't do that. She probably has a very low AMH, or her ovary reserves are all down. So we stimulate, like you mentioned, we give the medication, but it's not responding. They're not getting enough eggs. In that case, we have to use a donor egg. All right. So we take the donor egg and maybe your husband's sperm or a donor egg or a donor sperm. We fertilize it in the lab as well, and then we implant it. We transfer it into the surrogate mother. We have very strict policies and ethical considerations when it comes to surrogate mothers. We have a consent form the surrogate mother has to fill. We have a consent form the families would also have to fill. And everything is backed by law. And we also make sure the surrogate mothers are not abused. So one other thing we do is we house them, we feed them throughout the whole 9-month period. Their health education, their antenatal and everything is taken care of by the facility, because the aim is to make sure that the surrogate mother or the carrier is protected. And also patient's confidentiality is very, very important. So we try our best to make sure there's no form of contact between the surrogate mother and then the couple, unless of course they would want that. But then ethically, like I said, there are so many ethical considerations in that aspect. Yeah, so surrogacy is actually an option, actually. And I would also want to encourage people who may want to consider that but are scared or are worried to know that it's actually a form of fertility treatment, and we have people doing it and they are doing very well.
Awesome. This is amazing.
To add up to what she said, I wanted to find out from you whether you know anything about surrogacy and gestational carrier. Do you have any idea what it is?
You know, this is the first I'm really hearing a lot of this wonderful explanations about it. So I have no idea.
All right, so it's two words that we use interchangeably, and but then they mean absolutely two different things. Yes, so when we say someone is a surrogate mother, that person actually has a genetic link to the baby that she's carrying. So a prime example is you have two couples coming in, and then for whatever reason, we can't use the woman's eggs, right? And then she says we should use a donor egg. So we get that donor from the woman who's going to carry the baby. And then we take the husband's sperm, and then we fertilize the two of them. And we give it to the same woman who donated her eggs. That woman is a surrogate mother.
That's a surrogate
Yes,
mother.
because her egg is part of that baby that is being formed. That is the genetic link the two share. But then if we get the woman's egg, we get the woman's sperm, we fertilize the two, and for whatever reason, the woman says, I don't want to carry it. And we get somebody else to carry that baby, that person is just a gestational carrier, because she has no connection whatsoever.
No genetic link with the child.
Yes. Okay. So the word surrogate is basically when the two of them are there, there's a genetic link. And then the carrier is just somebody that we give to carry the baby. So yeah, I just want
to thanks for clear, because I personally will just use them interchangeably. So thanks for educating us. So with all these conversations that we've had, affordability is very important and crucial. Is this affordable to an average Ghanaian?
It depends on what your definition of an average Ghanaian is.
It could be relative.
Anyway,
help us understand what the range could look like potentially. And I know it could be case by case, but on average, what would you say the affordability looks like?
Okay, so then when my patients come, I just like to tell them that walking in here looking for a child is like deciding to sacrifice one car, for a baby, you know. I don't know, let's say a Corolla, maybe 120,000. That is up there. Even a Picanto is running around 60,000. So imagine sacrificing a Kia Picanto for a baby, all right? So then let's just talk about it. Our prices range, depending on what we are doing. Like Dr. Ntiama mentioned, we have different treatment options. So then we charge based on, first of all, what we are doing for you, the age of the woman, the eggs, your egg reserve, or let's say your ovarian reserve, the man's sperm quality. Are we doing surrogacy, or are we doing for yourself? Are we doing normal stimulation for normal intercourse? Are we doing an IUI? Are we doing an IVF? Are we using a donor sperm? Are we using a donor backup? If you are doing an IVF, are we freezing the remaining embryos? That's after you form the baby. Let's say we're able to get like 5 very good embryos. So when I say embryo, I mean the tiny, tiny babies you are yet to transfer. Are we transferring all of it? Or you would want us to store some for future that you probably can't for it? and then again surrogacy. So our price range, I'm not sure if Bank of Ghana allows us to quote in dollars, so I'll just have to be very careful with that. So let's just say a little above 50,000 for an initial budget would do. But if you come in for normal fertility screening, like, because usually we start from there, maybe 2,000 to 5,000 Ghana cedis for your initial consult, which would include your labs. I mean, like I said. And one good thing I think we do here is we know that, like I stated, it's a journey. You may not be successful in your first attempt. We do have considerations for people who may have to repeat a cycle. Like I said, it's patient based. In some patients, we tell them that, oh, okay, this is your second or your third cycle. We will support you, just pay for your medications, and then we do the others for you. In some patients, in some cases, like I mentioned, it's a home. So we try to understand, because you know how the economy is, and we are not just here to make profit, but we are here to make an impact in society and put smiles in the faces of so many families as much as possible. So if you're interested, you come and then we get talking.
Yeah,
and
definitely. Wow. Well, it's definitely been an awesome time with medical practitioners from Mediport Fertility Services right here in Ghana. And as you heard from our conversation, no situation is beyond their medical expertise. So if you're on a journey looking for fertility help, seek no further. Right here in Ghana, Mediport Fertility Services has everything you need. Thank you all for watching, and we'll see you next time.